Good afternoon, ladies and gentlemen. Welcome you all to this session of Friday ECO 2020, ECO Dhaka EU workshop organized by International Society of Cardiovascular Ultrasound, Bangladesh chapter. Today is a special day for us because we have got an internationally renowned teacher of echocardiography with us, Professor Thomas Binder, who is the director of Echocardiography Laboratory, Medical University of Vienna, Austria. And I welcome you all to this session of Meet the Expert. He will be talking on different aspects of evaluation of systolic function of left ventricle and right ventricle. We have got our president of the chapter, Professor Abdullah Shafi Majumder sir with us, and Dr. Monwarul, the co-moderator with us is in this session. And we have got a number of teachers and experts of echocardiography of Bangladesh with us. At the beginning of this session, may I request Professor Abdullah Shafi Majumder sir to say a few words about today's session.
Yes, good morning to Professor Thomas Binder and the greetings to the participants from Bangladesh. We are at the cross the noon time. So it is our great honor and pleasure to have Professor Thomas Binder as one of the presenters in this ECO workshop, which is being continuously taking place since June 2020 in the pandemic era. And we have heard of him for a long time that the Professor Thomas Binder is a very good teacher, and we expect him for many years back to have him in Bangladesh, but we failed to contact him or failed to invite him to come to Bangladesh. Now we take this opportunity over the webinar to meet him, and I welcome Professor Binder to meet with our fellows and our experts and teachers, and it is our great pleasure to have you to have the presentations, and I hope that everyone will have the very good experience in this afternoon in Bangladesh. Welcome, Professor Binder, and thank you very much for joining with us.
Thank you, sir. Dr. Thomas Binder studied medicine at the Medical University in Vienna, where he was also trained in internal medicine and cardiology. Research activities and clinical work brought him to the Huntington Memorial Research Institute in Pasadena, CA, and Loma Linda Medical Center, CA, USA. His main focus is echocardiography. Dr. Binder published numerous peer-reviewed articles in national and international journals. He is the author of the EchoFact book and contributed to several other textbooks dealing with echocardiography and cardiology. Dr. Binder was director of the Echocardiography Laboratory at the Medical University of Vienna for over 20 years and was recently appointed to the Teaching Center of the Medical University of Vienna to develop and implement new digital teaching strategies. He served on numerous national and international boards and is strongly engaged in all areas of clinical cardiology. Dr. Binder conducted and lectured at over 150 national and international echocardiography courses and is tutor for the Austrian American Foundation. In 2009, Dr. Binder founded the online platform 123sonography.com, which teaches diagnostic ultrasonogram to a global community. And every young cardiologist of Bangladesh know about him through this program of 123 sonography. May I request Dr. Thomas Binder to start his presentation, please.
Well, first of all, thank you very, very much for this invitation to talk here on this webinar, and also congratulations to this webinar, which is very, very successful and which I think has an important part in educating people around the world. And this is, of course, something which is very important for me as well. And as you see, my appointment now is bringing me more and more towards teaching. I'm now appointed at the Medical University of Vienna to spearhead the initiatives, especially now with the COVID pandemic that we have. There's been a huge push towards digital teaching, obviously, because we're all locked in. And this is something that I'm very, very happy to do for the coming years until maybe my retirement or beyond. I do not know. But coming back to echocardiography, it's always been my passion to teach. And the topic today is going to be left ventricular and right ventricular function, which I think is just such an important topic. But what I also believe needs a little bit of, I would say, debulking or correction, because over the years, we've accumulated more and more data, more and more techniques. It's actually gotten more complex than easier. And what I will try to do in this 1.5 hours, 2 hours is to maybe, highlight those things which I believe are important, just to reduce the complexity a little bit. So let me start. Let me just share my desktop with you. Okay. So I hope you can all see my desktop. Is that right? Yeah.
Yes.
Okay, so this is on left ventricular function, and I'll talk first a little bit about the mechanics of left ventricular function and the hemodynamics of it, because I think if you have a better understanding of how the heart functions and that it is a dynamic pump which adapts to certain conditions, you have, I think, the edge when it comes to estimating left ventricular function. So I think it's very important that you understand the principle of contractility, which is actually the force that can be produced by the myocardium. So what we're looking here is at how strong the muscle is, and that can be measured with DPDT. So this is something completely different, just to foreshadow, than ejection fraction, which is just a hemodynamic parameter that tells you how much blood is pumped out of the heart. And these things go in parallel, of course, but not always the same thing. But when it comes to left ventricular function, it's equally important that you understand that the shape of the ventricle also plays an important role, and that we have hemodynamic conditions such as pre and afterload, which influence ventricular function very, very strongly. If we look at contractility, be aware that the contractility can change. The heart is a dynamic organ or influenced by many, many factors. So sympathetic activation is an important factor. Imagine you have a patient who is lying in the echo lab and he comes in, he's just very anxious or nervous or just has maybe a panic syndrome, then this will definitely influence ejection fraction. So there will be variations just depending on how strongly the heart is activated. There's medications that can influence the heart, digitalis and all sorts of other things. And it's also an increase in afterload that plays a role on the contractility. Now, if we look at preload, this is also a very important factor. It depends on how the filling of the heart is. If there is a lot of filling, then the heart will have a lot of preload, which will actually increase contractility. If there's no preload, that will definitely reduce contractility. And I'll show you examples where people are hypovolemic. In such situations, you might have poor ventricular function, even though the patient does not have an underlying cardiac problem. And then what I just mentioned, I just said the volume, the filling pressures, and the inflow obstruction are factors that, of course, influence the preload. And then finally, talk about afterload. This is also very, very important because you have to understand that if a patient has an aortic stenosis, for example, then the heart has to pump against a high resistance. And in this situation, the ventricular function might look poor, but in reality, if you reduce this afterload, it can go back to normal completely. This is very important to understand, and you've got the Frank-Starling mechanism where the shape plays again a role. Where if you have a small ventricle, you can put up these pressures that you need to generate contraction. So these are all factors which play an important role. So what does this all mean for us in clinical practice? And let me now come back to, I think, just some clinical examples and to help you categorize and better understand the situations that we're confronted with in clinical practice. If we have a patient who has mitral regurgitation, we have a patient who has a reduction in afterload. The reduction in afterload is caused by the fact that there's a hole or that there's a defect in the mitral valve. So with every beat, we'll have blood flowing back into the left atrium, which makes it easier for the ventricle to contract. And this means that the ventricular function will look better than it actually is.
We are in the first page of your presentation. Are you moving the slides or?
Yes, I'm. What are you seeing now?
Is the tube well, left ventricular function, first slide only.
No, I'm 5 slides ahead. You're not seeing them?
No.
That's strange, because I'm now showing you slides and I'm showing you all sorts of things. Maybe I'll just discontinue this here. What do you see now?
Left ventricular function principles, contractility, shape, preload.
You see echo loops now?
Yes, yes.
Okay, what do you see now? Does this work? Do you see moving images?
Mitral regurgitation, aortic stenosis, and tamponade.
Okay, let's see. Does that work now? The next slide, do you see that?
No. No.
Okay, so that's strange. If you advance, it doesn't work. Well, I'll do a workaround. What I will do is, do you see it now? What do you see now?
Left ventricular function principles.
Okay, I think I know how I can steer it so that you see it to solve the problem. So, but now I think you see the. Do you see the echo loops now?
No loops. No loops.
It's not
Okay.
moving.
It's still pictures.
In pictures only.
That's strange. Do you see them echo loops now?
No, sir. Is this only still photographs of mitral regurgitation aortic? It's not moving.
Okay, so for some reason the loops are not running. What do you want me to do? Do you want me to maybe restart my?
You can restart. You can stop sharing the screen and can restart, or you can leave the webinar and join us again.
Yeah, you know what I'll do? I'll maybe just come in through a different browser. Okay, so please give me just a second. I'll be with you in a second with a different browser. Maybe it'll work better. One second, let me try something.
Okay, sir.
ফিরোজ তো ভালোই পয়েন্ট আউট করেছিল। আমিও মনে করছিলাম যে ওই একটা স্লাইড দিয়ে বোধহয় কথা বলে যাচ্ছে। হ্যাঁ,
শাহানা ফোন করছে স্যার। শাহানা ফোনে জানাইছে।
আমি লিখছিলাম স্যার বক্সে, চ্যাট বক্সে।
তুমি তোমারই দেখেছি। হ্যাঁ, তাহলে মেয়েদের আন্ডারস্ট্যান্ডিং ভালো আর কি। শাহানার নীলুফার তুমি বলছো পরে বোধহয়, শাহানার পরে।
হ্যাঁ, শাহরিয়ার কবি সবার আগে বলছে স্যার।
আচ্ছা আচ্ছা। He came back.
Okay, I'm back. Let's see if it works now. I'll just sharing my screen. 1 second. Okay, can you see my screen?
Yes, we can see your screen.
So what do you see now?
Is the first slide, left ventricular function.
You see the next slide?
No.
No, nothing moving here?
Nothing is moving.
Okay, that's strange.
Press down arrow key, please.
So, do you see anything moving here?
No, sir.
No.
That's interesting.
It has moved now.
So is it moving now?
We can see the slide, but it's not moving. Compensated heart failure.
I think I'll just have to deal with what we have. I'll just try to describe what we see. If that is okay with you?
Okay, sir. Okay.
But I think what I'll do is I'll just stay in this mode. You see the slides changing now, right?
This is a better one, sir. We can see the slide change.
Just let me see. Can you see it moving now?
Yes, yes, that's fine. That's
Okay,
fine.
that's how I'll do it. Okay, good.
Thank you, sir.
I think I'll just do this here. So what you see here is you see a patient with mitral regurgitation where we have a reduction in afterload. And the difficulty that we're confronted with here is, yes, we know that the left ventricular function looks better than it is, but we don't know how much better, because that depends on the degree of mitral regurgitation. So we kind of have to put that always into perspective. How much MR are we, and how much better does the ventricular function look? So there's a little bit of a guessing game here. But nevertheless, it's important to understand that if we operate on this patient, his ventricular function will definitely look worse after the operation than now. That's why we're also using a higher cutoff value for ejection fraction to decide whether or not the patient should go for surgery. Now here in the middle, what we see is we see a patient who has an increased afterload. We have a patient who has aortic stenosis, and definitely there is poor left ventricular function. So the question here will be is, will left ventricular function recover? Because if we treat the patient, if we treat aortic stenosis, his function will usually get better, depending on whether or not the ventricle has already been harmed. And here is an example of a patient with preload. Now, this is a reduction in preload. This is a patient who had a complication during a cath procedure. It was a rupture of the circumflex artery, and the patient had tamponade. And so here we had bleeding into the pericardial sac. And not only was the patient hypovolemic, but there was also a restriction from the outside, so there was no filling. And in this situation, the left ventricular function, which is completely normal previously, was definitely reduced. This is because there was no filling, so there was no contraction. So it's not only the diastolic function which was affected by the tamponade, but also systolic function. As soon as we tapped this patient, his function came back to normal. So I think this is important to also understand, and it does not only happen in tamponade. So coming back to the principles again, we talked about the contractility, the shape, the preload, the afterload, so all these hemodynamic parameters, but all of this has to be compensated, and ventricular function has to sustain enough blood to perfuse the organ. So there's a lot of mechanical factors of how the heart works, and I'll go into more detail of the mechanics of the heart and what the contraction pattern actually is. But just keep in mind that at the end, we have to keep a certain stroke volume so that the patient can survive. And this also means that the compensatory mechanisms will come into place. In other words, if we have a patient who has a reduction in contractility, the patient will then have sympathetic activation and dilatation maybe of the ventricle to increase the output. So these things must be considered, and depending on in which stage of the disease process we are, the heart will look a little bit different. So let me go through again some of these typical patterns, and I think this is so important to understand when you see a patient with a reduction in ejection fraction, a patient who has maybe dilated cardiomyopathy, to understand in which stage of the disease he actually is. This is a patient with acute myocardial, with acute MR. So in this situation, we will have a small ventricle, which is hyperdynamic, and this patient obviously has severe mitral regurgitation. So this patient has heart failure, but it looks completely different than, for example, this patient. So here is a patient with a flail leaflet, where you see there is a flail of the posterior leaflet, and you see that there is severe mitral regurgitation. So this MR is completely different. Both patients have some form of mitral heart failure. This patient, however, is compensated because here the ventricle is already dilated. And here is a patient with a chronic decompensated mitral regurgitation. So here you nicely see that this patient is still has severe mitral regurgitation, has a dilated ventricle, but his MR is so much that he cannot compensate anymore. So this patient will be highly severely symptomatic, just as this patient will, while this patient actually has a good compensation. How do we know that this patient is decompensated? Well, one of the factors that you can see in the 2D image is that his right ventricle function is poor. So this patient has high pressures in the right ventricle. Now let's go to the classification of heart failure in general. So imagine you've got a patient who comes to you and you know his ejection fraction has a certain value, it's reduced. This information alone is important, but it's not all you can get out of this, this study. Here again is an example of a compensated heart failure patient. You see he has a large ventricle, he has poor left ventricular function. So if you put that in the report, people will know that he has a problem, but it will definitely not tell you the entire story. If you look at the pulmonary pressure, which is normal, and also see that the patient doesn't have high filling pressures, then this will, of course, have a completely different meaning, this reduction in ejection fraction, namely that the patient, yes, he is compensated, he probably has rather good prognosis, and that treatment does not need to be altered. This is in contrast to this patient here. This patient also has poor ejection fraction, maybe a little bit worse than the one before, but here you see a different finding. You see that the patient has a very high E wave and a small A wave. And he also has probably not much pulmonary hypertension here. But the important thing is that this patient has such poor left ventricular function that his filling pressures are elevated, but that on the other side, the right ventricle is also poor in its function. And in general, this patient is not even able to generate high pulmonary pressures. So this is an example of a patient who has a much worse prognosis, who is much more severe than the patient before because he has decompensated heart failure. Here is another patient where we have heart failure, but here ejection fraction is normal. So in this situation, if you look at the pulse wave Doppler, you will find the explanation because he has a high E wave and a very small A wave, meaning that he has a restrictive filling pattern. The left atrium is also enlarged, and this patient has what we would call heart failure with preserved ejection fraction. So another form of heart failure. And finally, another category of heart failure is this here. This is a patient who has low output heart failure. So if you auscultate this patient, his lungs, you will not find any RALs. You will not find B lines on lung ultrasound. You will not find any congestion on the chest X-ray. Nevertheless, the patient is severely symptomatic. Why is this the case? Well, because he has low output heart failure. This patient is not able to generate enough blood to, circulate the blood. So this patient will have a very, very low LVOT velocity, which shows that he has low cardiac output. And all of these different findings are so important. If I just summarize, you have a patient with a reduction in ejection fraction. Look at the pulmonary pressure. This will tell you if he's decompensated or not, if he has pulmonary hypertension or not. Look at the filling pressures. If the patient has advanced diastolic dysfunction in the sense of maybe grade 2, grade 3, then this patient will also be decompensated, and it would make sense to actually install diuretics. If you have a patient who has very poor left ventricular function and a low LVOT velocity, as you're seeing here in this case, then this patient has low output heart failure. These are the patients who have the worst prognosis. These are the patients who need assist devices. These are the patients who should go for transplantation. These are the patients who are at risk. If not, they are already in cardiogenic shock. So look at the ejection fraction in a very variable condition, looking at all of these factors such as diastolic dysfunction, such as pulmonary hypertension, such as filling pressures, such as right ventricular function. All of these are important to better understand the impact and the meaning of reduction in left ventricular function. So the message here is not numbers, but clinical scenarios and clinical pictures are important. Let me now come just to myocardial mechanics, and I think many of you have seen these images on lectures and conferences all around the world. What you see here is you nicely see that the heart is not contracting regularly from inside to out in a radial direction, but it's actually twisting and turning. It's like taking a wet towel and just twisting it. Thereby, it not only increases its volume because it's moving inwards, but also because the length of the ventricle is changing. So this is the contractile pattern that actually the surgeons have always reported to us, because the surgeons have seen the heart pump. And if you have the opportunity to be part of such a surgical procedure, look at the heart and you'll see that it's really twisting and turning. This is important because this is a very, very effective way for the heart to generate so much change in blood volume despite relative little contractile changes in sense of myocardial fiber lengthening and shortening. So with relatively little shortening of the myocardial fibers, the heart is able to eject high percentages of blood, which makes the heart an extremely effective organ. So just to demonstrate what happens, we have a twisting motion that is different between the base and the apex. And we also have a change in the length of the ventricle. So this is diastole, this is systole. You see that there's actually a shortening in the ventricle, which means we have different components of contraction. We have the classic radial contraction, so the heart is moving inwards. This is what we see in a short axis view very nicely. We have circumferential contraction, where there's a little bit of twist that you can see also happening in a short axis view. And then we have the longitudinal contraction, which means that the ventricle is changing its length. This is a very, very important pattern, or very important part of contractility. And a little bit later, I'll go into more details to demonstrate how that pans out. But before I do so, let me just show you some echo loops that clearly demonstrate what I mean by this circumferential and radial motion. So if you look at the heart in a short axis view, you will see that there's a little bit of a twist. And the direction of this twist will depend on where you're imaging, if you're imaging more on the base or more in the apex. And the other thing you will see is that there is an inward motion. This is the radial motion. This is what we usually use most when we assess function, at least in a short axis view. We look at how much the endocardium is moving inwards. And this is a very important part, of course, in the visual assessment of left ventricle function. Now, these are old images from vector velocity imaging, which was one of the first technologies that used speckled tracking to track the motion of the heart. And what the company that produced these images did was they put these arrows to demonstrate the direction and also the speed, the magnitude with which the endocardium is moving. So what you see is you see these arrows actually circling a little bit. And this is the circumferential motion. At the same time, you see them move inwards. You see at the certain part of the cardiac cycle and systolic, we have those arrows all aligned towards the middle. So this purely shows that indeed this contractile pattern can be demonstrated with echo. Now this is a different display, which again shows you the motion. You see these different image points are moving in circles because they're moving radially and they're moving inward. So this again demonstrates that we can depict and we can also measure these different components of contractile function. Now, if we have a patient who has normal function, we'll have large circles. If a patient who has reduction in function, we see small circles. So all of this gives us a huge amount of information that has been now utilized in so many areas in speckled tracking to calculate strain and radial and circumferential strain, something which I believe is a very, very important, I would say, part of assessment of ventricular function. And I'll come to that a little bit later in more detail. But let me just go on and let me talk about this longitudinal function because it's so extremely important. Now, the longitudinal function means we have shortening of the length of the ventricle. The nice thing is that despite the fact that we have these modern technologies such as speckled tracking and vector velocity imaging, we do not necessarily need it because you can actually visually assess longitudinal function, at least globally, by looking at the mitral annular plane. You see, I put this arrow here in diastole and then in systole, and you see how this arrow moves, this line moves. And the difference between these two lines is a surrogate for global longitudinal function. So if you train your eye a little bit, and if you learn to also encompass the longitudinal function in your assessment of ventricular function, you will pick up patients who have, I would say, early systolic dysfunction, because the longitudinal function is probably the first component of contraction which you lose when the ventricle starts to fail. So the important part here is look at the motion of the annulus, and you can actually measure that too if you use the so-called MAPSE measurement, where you place an M mode here into the annulus and you see how the annulus moves, similar to the TAPSE that you use for the right heart. So the four-chamber view is actually, or the apical views in general, are the views which allow you to assess the longitudinal function. You cannot do this in a short axis view. But in the apical view, you can also look at radial function. So here you have 2 points of information, which is the inward motion and the longitudinal motion. And this is why the apical views are so important when you are assessing left ventricular function. You can see it all. You can see radial and you can see longitudinal function. So I'll talk a little bit later about spectral tracking, but at this point, it's just important for you to realize that the methodology that I showed you earlier, which we called velocity vector imaging, allows you to pick up each of these little speckles here and track them throughout the cardiac cycle, and then draw vectors that tell you how much these points move away or towards each other during the cardiac cycle. And then we can assign a number to them, which basically is the longitudinal strain percent value. And then we can put this value into a bullseye plot and get a color encoded display of how longitudinal function actually is. And in reality, we would expect this bullseye to be completely red. In this case, we have a reduction in function. You see that we have a reduction, especially here in the mid and in the basal segment. So this information you get here is on top of ejection fraction, which is actually only a measure of how much does the blood volume change. So here we're looking at myocardial function more on a myocardial, I would say, level. Not truly contractility, but it comes close to contractility, I would say. So keep that in mind. Then we have the possibility to also look at, the ejection fraction in respect to how does the ventricle contract, how much volume does it shift. But with 3D, we can even look at twist and torsion. So you see again how this heart is rotating, and you can see that it's rotating counterclockwise compared to the basal segments, and also changing in length. So the 3D also offers us to look at that. Now, I'm not proposing that this is something that you should do. I'm just demonstrating to you how the heart works and what needs to be better understood when we are looking at contractile function. To stay with some of these new technologies, we are now also able to track the blood pool. I guess many of you have realized that if you image someone in 2D, especially if patients are slim, you can actually see the blood flow. This has to do with the interaction between the imaging frequency, the ultrasound, and the blood flow. And this motion of the blood can actually be picked up digitally, and we can track, just as we track the myocardium, the blood flow. And this means that we can draw little vectors that you see here. So we see how the blood is flowing. And this allows us to more or less quantify or let's say study the flow within the heart. And what the interesting thing is that if patients have a reduction in ejection fraction, this pattern will change, because we know that there's actually vortex formation in normal hearts, meaning that the blood kind of swirls in the heart. And this kind of is a way to, I would say, store kinetic energy or stir energy in form of kinetics, which can then be released and which aid in the contraction of the heart. And we know that patients who have a distorted ventricle, such as you see in cardiomyopathy, these vortexes change, and therefore some of the energy is lost, which probably also contributes to poor outflow of the ventricle. In addition, we also know that certain vortex pattern, or let's put it this way, less flow in certain regions predispose maybe to thrombus formation. So these are methodologies which go beyond what we now look at ejection fraction. So it's more than just Simpson method and the other parameters we're looking at. So we're starting to understand much more of what really goes on when the ventricle fails. Just for you to understand that there's more to all of this. Yeah, here is again a patient with normal flow, and this is a patient with systolic dysfunction where you see a completely disturbed vortex flow. And this has been shown in numerous studies to play an influence and have an impact. Now let me just move on, and let's look at how we should quantify ejection fraction or function of the heart in clinical practice. And what I'll do now is I'll just lead you through some of these different methodologies, but not only will I just show you what these different parameters are, but I will give you my very personal feeling, and I will also mention where I think you should put most of your emphasis on, because I think we have to be honest, we're in a situation where we have hundreds and thousands of patients where we need to focus on those things which give us relative clinical information. And always in situations where you have many different parameters for one different point of information, none of these individual parameters are optimal, because otherwise you'd only need one and not all of these. And this is a situation with ejection fraction. So keep that in mind. Some of them have been proposed, I would say, maybe just for study purposes. And yes, they show something, but sometimes it's too complex and then they don't work in all situations. And many of them have never really been adapted by the community. And I think we should also learn from the community. If the community does not use it, then there's something wrong with the methodology, despite the fact that it might give you some form of information. So let's start with fractional shortening. Previously, when I started echocardiography, this was like the golden grail, holy grail. We would do an M mode and we'd calculate not only fractional shortening, but also calculate ejection fraction based on the Teichholz formula. Now, this is something we do not do anymore. In reality, M mode has really, really lost its importance. The reason is quite clear. First of all, we now know that there's not so many patients where you get optimal alignment of the M mode to guarantee that the ventricle is really measured correctly. Because if you have oblique views, obviously you'll overestimate the function. So to be honest, I'm still, of course, someone who does it, but I don't give too much value to it. The way we use fractional shortening is by just looking at how much does this diastolic versus the systolic end diastolic or the diameters change, and then calculate a percentage value. So this is what you see here, end diastolic and systolic, put these in relationship, and then we get the fractional shortening. Be aware that the fractional shortening is not the ejection fraction. Be aware that we get a value which is completely different. A normal value would be somewhere above probably 31%, between 25 and 43 would be the normal for females 27 to 45. So it must be about 25 to 27. And you can kind of multiply it by 2 to get a gross approximation for ejection fraction. But the problem with this measurement is it only works in reality in those ventricles which are normal in size. So that's a little bit of a problem, and I do not use fractional shortening, nor do I put it in my report anymore, nor is it being used in studies. So I would just say forget this value. But perform M mode. Sometimes you do see how the myocardium moves, and it does give you a little bit of information. So this is how I would use it semi-quantitatively. I look at the function based on how much change there is between systole and diastole. I also look at the septum and the posterior wall to see if there's actually contraction or not, if there's maybe a wall motion abnormality here. And I also use it to see if the contraction is synchronous. In other words, if the ejection fraction is reduced, but the add-on information we get is that we see that the septum is not contracting normally and that we actually have a delay in the septal contraction here. A patient who had massive tricuspid regurgitation, so there's abnormal septal motion here. So be aware that M-mode has a little bit of a role, but maybe not as much as it used to have in the past. Again, here are some of the problems or pitfalls. If you want to use the calculations of a fractional area, a fractional change, is that you have a problem in situations where you have dysynchrony. Here's a patient who has early systolic activation, and then you have the contraction of the posterolateral wall here. So where are you going to measure end diastole, and where do you measure end systole? So this is one of the limitations, one of the main limitations. In addition, if you look at a patient who might have an infarct here, then this is not representative of the entire ventricle. So it's just one line, not much information. Ever since we have 2D, I think we have the opportunity to look at many more things than just one certain region. Another problem of fractional shortening is that if you have a small ventricle, you will have the sides of the ventricle come into your field of view. The posterolateral or anterolateral papillary muscle, for example, and that will kind of give you M-modes where you think this is the true end systolic size, but in reality, you're missing out on part of the ventricle because you're just obscuring the view caused by this papillary muscle. Yeah, this is the Teicholz formula now, which we're not using anymore. Just to mention again that this is something of the past. Let me come to something now where I think you should really practice and where you should put a lot of your emphasis in, and that is the whole issue of eyeballing. Now, I know this is maybe not what we would love to have, because we always cling to numbers. We love to have a single value that gives us a categorization, but the truth is that in many situations it's much more complex, and a single number does not always describe the problem, nor can we generate numbers which are so exact that we can rely on them. And in any case, whatever form of quantification method you're using, eyeballing will always form the backbone against what we have to control our measurements with. So in reality, what many people are doing is, and I agree, I do the same thing, is we look at the ventricle, we take a look at how function is, we kind of have in the back of our head a certain value, and then we perform a Simpson calculation. And if the measurement fits, then we're happy. If it doesn't fit, what do? We measure again. And if it still doesn't fit, we measure again. So actually we're moving those values to what we see in our eye, which is not a bad thing, because we can't live with these discrepancies. And if our eye is good, and if we have trained, then the eye has a much higher value than, I would say, a bad measurement. And here are some examples that demonstrate that it's not so difficult to judge ejection fraction. Take a look at this image here. Short axis view. Of course, we're only looking at radial function, but I don't think anybody here in this webinar would think that this function is reduced. This is clearly a normal, actually hyperdynamic left ventricle function. So this is very easy to look at. Now, on the other side of the spectrum, here's a patient with this ventricle. And again, I don't think anybody here in this webinar will think that this is a normal function. This is a massively severe reduced function. So just to demonstrate that it's very easy to discern these patients between hyperdynamic and normal and severely reduced. It might be a little bit more difficult if you have patients who are in between. So this patient probably has normal to maybe borderline ejection fraction, and this is a patient who has moderate, maybe reduction ejection fraction. But still, if you compare this ejection fraction here to this, you will clearly see that this patient has a problem. So even though we might not always be able to put a number on the ventricle, we can categorize it in such a way that it provides very valuable clinical information. Yeah. So here again, hyperdynamic, normal, moderately reduced, and severely reduced. There's been a number of different studies who've looked at how good is eyeballing compared to calculations of ejection fraction based on Simpson and 3D. And one very important finding is always part of these studies, and that is it's a matter of experience. If you have a lot of experience, if you've seen a lot of ventricles, then you will be at least as good as 3D and Simpson method. And I would probably challenge, and I would say that we're actually better than Simpson method, especially in those patients who have poor image quality, because our eye is able to perform, I would say, extrapolations where we don't see an endocardial contour. We're able to kind of sense where the endocardium is, something that the machines cannot do. What is coming here on the horizon? Well, one thing that we do see now is that we have AI, which might, in a way, start to mimic our visual assessment of ejection fraction. I've seen systems which work quite well. They're trained by experienced readers, and they take into account not only the movement of the endocardium, but they take the whole pattern, the size of the ventricle, the shading, how the speckles are moving. So there's much more information than just looking at the endocardium. And this is actually also what we do when we assess left ventricle function. So I think in the future, I can envision a system where you would just record an image loop and it's kind of fed into a database, and we have some AI, I would say, method that gives you maybe a beat-to-beat ejection fraction on your screen. I've seen these things already in clinical practice. We've done some studies on them, and they work very, very good. So, but when we come back to assessment of ejection fraction based on our visual information, I think what we have is we have the advantage that we are able to interpret ejection fraction or left ventricle function better than any machine algorithm does, because we have to be aware that there are some limitations and problems that machines or that ejection fraction calculations using Simpsons cannot bypass. For example, we know that patients who have dysynchrony are very, very difficult to assess because we cannot define when end systole, when end diastole is. Let me see which of these ventricles shows us dysynchrony. Okay, well, none of them. Well, anyway, so a left bundle branch block is always a bit of a problem. The other very, very important thing is, and I'm always running around, you know, from one lecture to the other trying to preach this, because this is, I think, one of the most important mistakes that we do when we calculate ventricular function, is that we need to understand that ejection fraction is a function of ventricular size. Remember, we've got end diastolic minus end systolic divided by end diastolic. So end diastolic diameters are very, very important. The key message here is the larger a ventricle is, the less ejection fraction you need to generate the same stroke volume. So if you have a large ventricle and it's moving like this, it will still shift a lot of blood. If you have a small ventricle, it has to be hypercontractile to generate the stroke volume that you need to sustain body function. And this is why ventricular function will always look better in small ventricles. So this is an example here on the bottom that demonstrates that. You see, small ventricle, ejection fraction is poor, but in reality, if we know this, we can assume that in reality, ejection fraction is even worse than we estimate from this here, because this ventricle cannot even compensate anymore, because small ventricles will usually compensate by increasing catecholamines. That's why their small ventricles are frequently hyperdynamic. So this is very, very important. The other consideration we can make is that we look at longitudinal function. I showed you that earlier. It's something that we need to incorporate into our assessment of ventricular function. Finally, it's easier for us to look at the whole contractile function in the perspective of heart rate. If you have a patient who has a very high heart rate, obviously the diastole will be much shorter, and especially if heart rates are very, very high, function will look worse than they actually are if the ventricle would be filled, for example, during rate control in atrial fibrillation. So this is something we also need to understand. And then finally, if you have regional wall motion abnormalities, I mean, just think of a patient with a myocardial infarction, maybe even in the lateral region. In these situations, a biplan Simpson will not tell you anything about this part of the ventricle because you're only doing the 2 and the 4 chamber view. So you might have the lateral wall in your outside your region of measurement. So this is something that we can do when we assess the ventricle. So again, eyeballing is a very, very important factor. I've mentioned right at the beginning that we need to look at the size of the ventricle, and we need to understand that volume overload is a specific situation which causes us to believe that the ventricle is better than it actually is. Here is an example of a patient with a large ventricle. See, ventricle function is normal, but don't forget that this patient has aortic regurgitation. So he's volume overloaded, which means that the ventricle is probably not as good as you might think he is. Let me just go. I'll just move away from here. So let me now turn to ejection fraction. Ejection fraction is the holy grail. So if you go to the internet, you enter the search term ejection fraction, you will find millions of hits. All the studies have been performed with ejection fraction, and it's a neat parameter. It's a simple parameter. You know, people love it, but in reality, I think it's an outdated parameter because it only tells you a small part of what is really going on. It only shows you how much volume you're ejecting in relationship to the entire volume of the ventricle. So it's a percentage value. So you're looking at the volume shift. You're not looking at how good the myocardium is functioning. You're not looking at how is the compensatory state? Is he at rest? Is he under exercise? All of these things do not really pan out if you look at just a single value. So this is one of the major problems of ejection fraction. In reality, just for you to understand how you calculate ejection fraction, it's end diastolic volume minus end systolic volume divided by end diastolic volume times 100, and then you get a percentage value. Obviously, the heart does not eject all of the blood that is in the heart. And diastole, it only ejects 50, 60, 70%. And this value is the ejection fraction. Okay, just to remind you, there's been a publication which was published in 2015 where we have the standardized normal values for all of the measurements of the heart. And here, the meta-analysis has shown that the cutoff value for males should be 52 and for females should be 54. Okay, I agree that this is very important to understand, but be aware that we have measurement errors somewhere in the range of maybe 10, sometimes 15%. This again shows you the weakness of ejection fraction, and should just make you very cautious, even though we have very exact cutoff values 52, 54. That we're frequent a situation where we just move the cursor a little bit to the left or the right, and we're up or below these values. So we're on pretty thin ice here. Just to mention some of the limitations, can we always track the endocardial borders? Yes, in good image quality, maybe, but in poor image quality, it'll be difficult. We've got this whole issue of foreshortening the ventricle. We're not really calculating the true end diastolic volume. We have the problem of that the posterolateral wall and the anterior septum is not part of the calculation since we're only doing a 2 and a 4 chamber view. I mentioned the problem of dysynchrony already. So ejection fraction has its limitations. What do I do in clinical practice? Yes, I would perform Simpson. I would, of course, always question if this value can be true in relationship to my visual assessment. I more and more use the automatic measurement programs which are built into the system. So frequently you would have a program that does that automatically, maybe sometimes even in combination with strain. My experience here is that the measurements are usually a little bit less than what I would do if I do a manual tracing or tracking. Maybe this has to be considered also when we generate new normal values, that there's a difference between the automatic measurements and the classic Simpson method. And I would perform a Simpson method only in those patients where I can be sure that it can reliably be performed. So if you have poor image quality, I would just leave it. I would then only look at my visual assessment of function, and I would grade left ventricular function, normal, mildly reduced, severely reduced. And I would also, for example, use intermediate grades. So mild to moderate, moderate to severe, and massive would be kind of 3+, or some would call it 4. So this is how I would go about. So yes, Simpson, mostly automatic. For those who are working in a clinical university environment and you're doing studies, maybe 3D. Most of us do not have 3D in the clinical arena. And if you have poor image quality, and if you really need an ejection fraction, for what reason ever, I would use a contrast study, because that can really, really increase the delineation of the endocardium. Good, so this is what I would do for ejection fraction and the Simpson method. Let me now turn to the stroke volume. This is an interesting and very important parameter, because if we look at, for example, cath studies, right heart catheter, the measurements we get here is stroke volume as a parameter of cardiac function. And I think it's a very, very good and interesting parameter. Still, we have to be aware that if we look at the, there's two methods we can use. The one method is using Doppler. This is what you're seeing here. Here you would first measure the diameter of the LVOT. That helps you to calculate the radius, the cross-sectional area. And then you would multiply that by what we call the velocity tracing of the LVOT here. And this velocity is then multiplied by the cross-sectional area, and then you would get the stroke volume. So this is a nice parameter. Where would I use it? I would not use it in every patient, but only in those where ejection fraction is moderate to severely reduced, because then I can discern these patients who have low cardiac output. So this is a very, very important parameter to help me delineate patients who have, compensated versus decompensated versus low output cases. And you can do that actually not only across the LVOT, but if there's no shunt, you can do the same over the pulmonary valve or pulmonary artery. So this is the one way you can do it. The other way you can do it is by simply doing the Simpson method. And then with the Simpson method, you get end systolic and end diastolic volumes. And then you just take the difference, and the difference should be the stroke volume. The truth is that if you use these values, they very rarely correlate with what you get with the Doppler values. Why is that so? Well, because both parameters are not very good parameters. And I think the main measurement error lies in the Simpson method, which again shows me that the Simpson method is not as good as we think it is. But still, this is something that you can do, even though 90% of us would probably use the Doppler method, which I also believe is more reliable. So this gives you very important information. When you look at the stroke volume, you have a normal stroke volume at rest between 70 and 110. Be aware, though, that when patients are excited, or if you have a patient who has is an athlete, you have different parameters. Patients who are athletes usually have rather high stroke volumes at rest, and they can increase the stroke volumes over proportionally if they exercise. So stroke volume is important, but it's equally important to look at cardiac index and cardiac output, because the stroke volume depends on the heart rate. If you have someone who has a low heart rate, his stroke volume will be relatively high. The higher the heart rate, the lower the stroke volume will be. So you have to multiply the stroke volume with the heart rate to get the true cardiac output. This is probably the better parameter, because it tells you how much blood the patient is really throwing out of the heart in a certain period of time, for example, in 1 minute. So multiply this and get the cardiac output, and this helps you even more. What do I do in clinical practice? Again, I would not always calculate all these parameters, such as stroke volume, cardiac output. Sometimes I would just use the velocity time integral, especially if I want to compare one patient from one exam to the next. Here, I would assume that the LVOT diameter will not change. So the VTI alone gives you the information if something is changing or not. A normal VTI would be in the range of maybe 23, 25. If you have a velocity time integral below maybe 15, or I've seen patients with 8 or 7, this means they have a very, very poor cardiac output. And even though you don't have a true measure for stroke volume, it will already tell you that the output is reduced. So again, this is where you would need stroke volume. I talked about this. This would be for other clinical conditions where stroke volume would be important. Let me show you again an example. This is a patient with very low output, and you see that this curve is not very broad. So we have an early termination of systole with a velocity which is just barely over 0.2. So this is a patient who probably has a velocity time integral of maybe 10, 12, or even less. And if you use the calculations that I showed you previously, you will get a stroke volume of only 40 milliliters and a cardiac output of 2.5 liters per minute. There are some limitations. You've got this measurement error of the LVOT, which you can avoid if you only look at the velocity time integral. And you should not have any aortic regurgitation, because if you have aortic regurgitation, you have pendule flow between the ventricle and the aorta, which increases the stroke volume or the calculations of stroke volume. Methodological problems you might have is that you have interference with the aortic velocity signal. If you go too close with your pulse wave Doppler to the aortic valve and the patient has aortic stenosis, then you will have high velocities which are not representative of true stroke volume. You cannot use it if the patient has the SAM or LVOT obstruction, and be aware that you will have patients, especially in atrial fibrillation, or also in patients who have very, very poor left ventricular function, where you have a beat-to-beat variability of the stroke volume. So you need to average several beats here. This is a very important parameter. I don't use it in all patients, but I would say in many patients. DPDT, contractility. We talked about that already. This is a parameter that tells you how good the force or the magnitude of contractility actually is. And it's a parameter that we can calculate from the MR signal. If we have a patient who has mitral regurgitation, we get a signal which looks like this. And what we're interested in is this very first part of the curve. And the important part is between 1 and 3 meters, because we look at the steepness of the curve in this region. Here, 1 and 3 meters, this is the steepness. In other words, the time duration from here to here would help us to determine the DPDT, which we then just put into this formula here, and then calculate the DPDT. Those are the normal values between or above 1,200, borderline 800 to 1,200. So if you have a DPDT below 500, the patient has a reduction in contractility. We've used this parameter very much, especially when we were looking at CRT patients, and that had kind of was part of our protocol, and it works quite well. You do need to have a patient with MR, otherwise you cannot perform this measurement. The problem that you have here is that very small differences in the position of the trait of the slope makes a huge difference with relationship to DPDT. So you have to be very, very exact, and you have to have a very good curve. This is an example of a patient here with poor left ventricular function. He does have a little bit of MR that helps us to measure the continuous wave. And you see that here, this curve is almost like a dagger. And this is the region we're looking at, 1 to 3 meters. Okay. There's been numerous studies that have shown that it's a prognostic factor. I don't know why I don't go into that. Do we use it in a routine fashion? I would say no. Only if we do studying purposes, and if we want to, I would say, control patients or want to see how they pan out after some procedure, would we use it. But it's still important, because sometimes I'd use this parameter semi-quantitatively. So I'd perform a continuous wave Doppler across the mitral valve, and you can kind of visually already see which of the curves which have a steep curve and which don't have a steep curve. So if you have a research facility, or if you want to get more information about ejection fraction, a function of the heart, I think it's a good parameter, but I would not do that routinely. I think that would be overdoing it, and it's a little bit redundant because we can get the same information from the parameters I showed you previously, and because there's a much more important parameter that we have, which is speckle tracking and strain. So this is something that I think is a real game changer. This is something that I'm sure will have its impact in the future. And I think that in the long run, this will not replace ejection fraction, but it will be an add-on that we will eventually kind of find different patterns of patients depending on how good their ejection fraction is and how good their strain is. I'll explain to you later why this is so important. To better understand speckle tracking, this is just an image which maybe helps you to conceptualize the idea a little bit better. This is a muscle cell. This is a smooth muscle cell of the heart, and you see how it's contracting. And in reality, this is what we'd like to know about the ventricle, not how much volume is shifting. We want to know how good is the muscle fiber contracting. And the speckle tracking comes pretty close to this concept. Why? Because it's actually tracking the individual speckles. And a speckle is a border between two different echogenicities. And it's where you would have maybe a muscle fiber in this versus a different direction. So you have a different angulation of the ultrasound beam, and there you have border zones. And so you'd be looking at muscle fibers in a certain way. And you can actually see how these muscle fibers change or move during the contractile process. So yellow and red would be the same muscle fiber during systole and diastole. And so you can draw vectors. You can see how these different fibers move from the old to the new location. And if you have a lot of these speckles, you can do calculations that gives you, a general motion and percentage difference between systole and diastole with relationship to the distance between them. And you can calculate numbers, which basically are very easy to understand. When you're looking at longitudinal strain, the parameter you get is, think of it as percentage shortage of the myocardium. So a value of 10 would mean, or minus 10 would mean, the myocardial fiber is contracting 10%. And that's a very nice way to understand it. And with the new technologies we have at hand, we can actually not only look at the global shortening of the myocardium, but at certain regions, here, 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 here. And therefore, we can assign different color values to them and do color plots, put them against time, put them against location. We can draw curves of how the shortening happens during systole and diastole, during the cardiac cycle. So there's a lot of information in these. And so we're starting to understand not only how much the contraction of the myocardium is, but also when it occurs, how it occurs, and how it occurs in relationship to other segments. And the way that most companies are now displaying this information is that they're using this bullseye display, which gives you a representation of the ventricle, the apical, the mid, and the basal segments. These are the septal segments. Those are the lateral segments. So in summary, we can see how is the global longitudinal strain. This is the average value of all of these parameters. And how is the regional strain in certain regions. Why is this parameter so good? Well, the information we get is a very subtle one. Longitudinal strain is reduced before we see a drop in ejection fraction. This means it's a subclinical parameter. This means you can detect a cardiac problem before we see it with ejection fraction, and also before we see it with the eye. So this is truly a breakthrough technology, and the methodology is getting better and better. I must agree that not all vendors have the same quality, and that there's a little bit of difference between the vendors, which is probably the main reason that this technology has not been utilized in every laboratory so far. I think that the truth is that at some point we will probably have machines which do it so automatically that you'll have a instant strain value on the top of the screen, which is constantly recorded while we image. I think something in that direction will come. But be aware that this is something which is here to stay and it will not go away. And the earlier you start to deal with this technology, the better you will probably be in the assessment of those parameters. So the advantage of this technology is not only that we can look at subclinical dysfunction and global left ventricular function, but we can look at it also regionally. In other words, we can detect areas which have better or worse function. And this brings us into this whole area of coronary artery disease and detecting the ischemia and detecting scars, which is one of the most difficult things, I think, in echocardiography. So this regional wall motion analysis, for example, here in this case, where you see a patient who has an apical infarct, works very, very well. You see apex, no contraction, the rest is doing fine. Another very important part of this speckle tracking, or I would say advantage, is that we can look at the timing. We can look at the timing of a surgery, for example. If you have a patient who has a valvular heart problem, for example, aortic stenosis, and we see that the strain is getting worse, there is now compelling evidence that we are better than ejection fraction in determining which patients should receive an operation and who should not. We know that patients who have a reduction in strain are those who do not recover as well after operation as those who have a normal strain. So there's so much information in aortic stenosis, of course. So there's so much information here, and the guidelines will be rewritten. I'm 100% sure. It will take some time because there has to be some standardization, and it probably needs all the vendors to work together on this endeavor, but I'm sure that it will be part of the guidelines. We can use it to detect subclinical function regionally in myocarditis. Myocarditis is one of these very difficult areas where you have not, a lot to really determine whether a patient really has myocarditis. Yes, we've got MR, which has its limitations as well. We've got the pericardial effusion, and we can see wall motion abnormalities. But frequently, patients have subtle abnormalities that can be picked up with strain. So strain can be used here with caution, but there's been numerous studies now that show how important it is. And then finally, we can use it for follow-up purposes. Look at this here. This is one patient, and you see that his global left ventricular function is continuously deteriorating. And you know how difficult it is to detect that with a normal ejection fraction, given the fact that we have a measurement error of 10 to 15%. But here it's so easily done. You see a value which is much more reliable, I think, than ejection fraction. And you can visualize that and communicate that so nicely even to a cardiovascular surgeon. So this is my conclusion for left ventricular function. I hope that you understand the main points, and that you understand that despite the fact that we have all these parameters, and I did not go into all of them. I did not mention the TAE index, which I believe has no clinical role. I did not look at tissue Doppler imaging, which has been replaced by speckle tracking. I think if you focus on these few parameters, you will probably get a good understanding, especially if you understand the cardiac function which underlies ejection fraction. If you understand the pitfalls, if you understand that the size plays a role, if you understand that pre-afterload plays a role, then I think you will probably have a head start when it comes to estimating ejection left ventricular function. Be aware that left ventricular function is more than ejection fraction, that we're not looking at contraction, but we're looking at the shift of blood, which is certainly important, but not the entire story. And be aware that you will have patients who have a normal ejection fraction, but still an abnormal left ventricular function. Patients who have a reduction in strain, for example. The patients who have small ventricles, for example. Be aware that if you write something in your report, you have to put that into clinical perspective. What does that really mean for the patient? Patient with a reduction ejection fraction or left ventricular function and mitral regurgitation clearly means that this is a surgical candidate. Use these three parameters mainly, which is eyeballing, again eyeballing, train, practice, but add Simpson, maybe 3D if you have, and try to perform strain in as many patients as you can. If you do not have strain, at least look at the longinal motion of the mitral annulus. That gives you some information as well. And then finally, I think, which is so important, don't cling to numbers. Be very skeptic. I've seen that happen in so many situations. A patient comes with cardiomyopathy and you've got a value of 35 as a cutoff value to give him an ICD, and then you calculate and the patient has 36. What do you do? But then you look at them and you say, God, I mean, this patient, I think, really should get a defibrillator. What are you going to do? Well, many people, and I've seen that happen, they would do it again and then they get 34. So, you know, we have to be aware that these numbers are good as a gross reference, but that they do not tell the entire story. So this brings me to the end of my lecture on left ventricular function. Maybe I should just pause here for a bit and maybe ask if there's some questions before I jump into the topic of right ventricular function. Is that all right?
Yes, I think that would be all right. If we can, if we have got some question for you from the part of our panelists and the participants, you can ask me. For the panelists, if you have got any question regarding this presentation, regarding the...
First of all, thank you, Professor Binder, for the elaborate discussion. Not only you tell about the applied portion, also you have got the background theory also. That is very important for the echocardiographer to understand the background theory to translate into the practical applications. One of my observation is that even in the classification of the heart failure, you see there is a reduced ejection fraction, mid-range, and PSAP, and there is also the straight numbers of the ejection fractions. That is very difficult. Also in the indications of the CRT, there is a specific numbers. What is your idea about that?
You mean you mean the cutoff value?
Yeah, cutoff value. This is the cutoff value. 50% or 45% is the cutoff value of the reduced ejection fraction. And so there is a lot of trials are undergoing, and it failed to show that this drug is effective in this way and that drug is effective in that way. I think we have to have some clear ideas that the ejection fraction is not that important to our colleagues or to the fellows in the medicine and other subjects.
Yeah, I mean, I clearly agree. I think I'll just tell you some anecdotal stories. We were part of a study where we're looking at bypass versus interventional therapy in coronary artery disease in patients with poor left ventricular function. And we sent our data to a core lab. And the result was that the ejection calculations of the core lab did not in any way correlate with our data. And when the core lab looked at ejection fraction among the different core labs, different labs, they also had a high variability, sometimes in the range of 30%. Are you still here? Can you hear me?
Yeah.
I can hear you.
Yeah. So what I'm trying to say is that in the clinical world, it looks different than you see in the publications. I'm not saying that these publications are not correct, but but a lot of experts do them. People who have a lot of experience. Sometimes only patients are used with good image quality. This is not the real world. The real world out there is that the variation is high, and even if you talk to some of these colleagues, at the dinner table after a lecture or a seminar, and you ask them, well, how? The truth is that there are many, many limitations. I think it's getting better. I think that you should still use it, but you should use it with caution. And what is very important is also to understand that especially ejection fractions below 35 do not give us additional information anymore. This is very important because we lose a lot of information. Even if someone has maybe 30 or 20 or 25, it doesn't give us incremental information. But this is not the case with strain. A strain value of minus 12 is completely different than a strain value of minus 9, even though both might be severely reduced. So what I'm trying to say is that ejection fraction just has so many pitfalls. You just have to be honest. But as it always takes many, many, many years and generations to change something, especially because momentum of ejection fraction and the masses of publications is so huge that we do not question it anymore. And I think it just needs some rethinking.
Right. Thank you.
May I ask a question, sir?
Sure.
Yeah. Assalamu alaikum, sir. We are very glad to hear your beautiful demonstration about the left ventricular systolic function. I want to know about the what we should write or a sample report about the LV systolic function, echo report. What should we write down? A sample report or ideal report regarding LV systolic function.
Yeah.
Echo report.
I think that a report needs more than just a very short comment and a number, such as good, bad, poor. I think what you need is you need an explanation. I'll give you just a few examples. You would see a report that says normal ejection fraction, but moderately reduced strain. Okay, that would be, for example, or hyperdynamic left ventricle function, parenthesis, in a small ventricle, you will be overestimating true ventricular function. Or you would have something like normal ejection fraction, however, in the setting of reduced afterload. You know, things like this, where you kind of put this information into a clinical context. I think that is important for people to get aware of the limitations of ejection fraction. That's how I would go about.
Thank you, sir.
I want to ask something.
Yes, Dr. Rajiv, go on.
Firstly, I want to thank Professor Thomas Binder. Actually, he is my virtual echocardiography teacher from very beginning. From beginning, I have learned echocardiography from your virtual demonstrations classes long ago. So I have actually want to note about two things. Number one, whether this global strain, longitudinal strain, is reproducible or it is reliable or not. And number two is this DPDT. Actually, this DPDT, is it changed with the heart rate, or is it reliable in that sense?
Yeah.
And again, thank you for understanding about the LV function beyond ejection fraction. Thank you.
Dr. Rajiv Ghosh, first of all, I'm very honored that I have a student that I didn't know was a student of mine. This is a kind of a bizarre situation in this modern world where you have people who follow you and you do not know personally. So I'm very happy to meet you here personally, and I'm happy if I was able to contribute in some way. To answer your questions, the reliability. I'll give you a little bit of an inside opinion of this. The problem is that one company started with this strain analysis, and they, of course, do not really open their technology to the others. There is a black box there in how strain is calculated. And now you've got different companies with different black boxes, and we do not really know what is happening. So the community, the European society decided, well, let's do some studies and let's compare the different values of the different vendors. And the first results were very, very frustrating because they showed that everybody gets something different. In the meantime, however, the companies have really, really worked hard and this gap is closing more and more, especially for global function. For regional, it's still a bit of a problem because you don't have so much data because the region is smaller. So yes, the reproducibility is getting better and better, but the societies cannot open speckle tracking to the wide masses if this technology is not available to all major vendors in a quality which is high. If we say, okay, there's only one or two companies who can do it and the rest, it doesn't work, but we propose it as a methodology to say if someone should be operated or not, that would make a lot of false mistakes. So the societies, I think, are a little bit hesitant to put that into the guidelines. But it's going in this direction. And I think if those vendors who have the edge don't open up in some way or other, they're probably blocking their own usage of speckle tracking in the global community.
Okay. Thank you. Dr. Monwarul, you have something to add?
Sir, I have one question. I am accustomed with Vivid E95 machine, and I feel comfort with this machine. And in this machine, there is a function, auto LVEF. That is an automated function. In that mode, just automated LVEF can be estimated in two views, apical 4-chamber and apical 2-chamber. And how much is this reliable? And can we just average these two values to make some assumption?
Well, I think the advantage of all these packages is that it makes things easier. It makes them more reproducible. It makes them quicker. Yes. Some of the limitations, however, will always remain. For example, if you have an infarct in the lateral wall, you cannot really rely on the Simpson method. And I think all of these systems must be visually checked. If you see that the endocardium is good, then you can rely on them. Often you need to correct to a certain degree. So often they're not really fully automatic, but they're semi-automatic anyway. So yes, I use them. I think they're good. They're getting better and better. And I think that they're starting to use AI technology already. So we can expect that this will at some point replace the manual tracing altogether. Especially because they can do many things at the same time. They can calculate strain, they can look at the LA volume, they can look at RA volume, they can look at all sorts of different things in parallel. I think that this is definitely something, but again, my feeling is that the ejection fractions you get with these methodologies are usually lower than what you get with the manual contouring, and they do not fit together with the guidelines. So frequently you'll have 45 or 46 in a completely normal ventricle. You know, by definition, this would be a reduced ventricle.
And my impression is that overall, our eyeballing and overall impression is the best one, because even for strain calculation, there are so many limitations, like the in obese patients or patients with COPD, with poor equindo, we cannot do strain. With arrhythmias, so many limitations.
I mean, I think you in India and in Bangladesh have an advantage because the patients you image usually have a much better image quality than we see in many parts of the Western world. So it's difficult. It's difficult. I agree.
Yes.
Can I ask a question?
Yes, Dr. Rabiul.
Thank you, Thomas Binder. I am one of your global students, and I also met you in Jaipur, India 2 years back. You have forgotten probably. My question is that, can we use the regional straining pattern in a patient who cannot go for the stress test, something like that, exercise tolerance test or anything else? So whether if we get reduced strain in a regional part in the bullseye, whether we can take the patient as a take the strain as a clinical information to treat the patient as the minor ischemia, the patient has ischemia or not.
Yeah. Well, good to see you again. I think we met in the last meeting. Yes, in Bangalore.
Yes.
Yeah.
Right.
Okay.
Yes.
Well, good to see you again.
Yes. Sir,
well, the answer is yes and no. Obviously, it would be the wish that you would even spare a stress ultrasound exam, and you just put the transducer in a rest ECG echo, and you get the information. But it does not work. Mostly, it does not work that way. There are situations, though, where an abnormal strain pattern can point to coronary artery disease. There's been numerous studies, and I've seen that also happening if you have a patient who has a 3-vessel disease or a main left, that these patients might have no angina. They might have no wall notion abnormalities, but they do have an abnormal strain in that region. So yes, you can probably find these patients who have a coronary artery disease. It might be, I would say, not very sensitive and not very specific, but it can point to a coronary artery disease problem. And then what you would also see is you would see it in patients who have, I would say, a lot of risk factors such as diabetes. These patients might also have, or microvascular disease, an abnormal strain pattern where you do not see anything. However, again, the sensitivity is not high. There's many other reasons why a strain pattern can be reduced, such as LVH, such as maybe even athletes might have a poor basal strain value. So yes, we can see it, but it's probably not good enough to use it as a routine measurement or as a screening measurement.
Okay, thank you.
Can I make a comment on this?
Sure.
There was an elegant study in United States showing that when we use this strain in addition to the stress during stress echocardiography, in some cases we have the sensitivity of 100%. After looking that, we also tried to do some stress strain, and as has been said, in majority of the cases we actually failed to obtain any result from that. But there have been an interesting article in 2020 which is telling about the torsional motion during exercise. If the detorsional motion is reduced after doing the stress exercise or pharmacological agent, during detorsion, if there is lack of the detorsion effect, then it indicates the inducible ischemia. Probably that is one of the way the strain can be useful when we add this strain along with the stress test.
Yeah, no, I think what I pertained to before was the rest stress, the rest echo exam if we can detect ischemia. But what you said is 100% true. Obviously, it's an interesting tool to use under stress testing. And there's been, as you mentioned, numerous studies that have shown the value of spectral tracking in stress testing. Thank you.
Can we go to the next part of the presentation?
Yes, I'm happy. This is now the right ventricle. Let me again share my screen. 1 second. Yeah, I'm happy that it does work out at the end. I think we found a workaround that you can at least see the moving images. Can you see them well now?
Yes, we can see.
Yeah. So this is now on right ventricle function. Again, the right ventricle function, they've always called it the forgotten chamber, which I don't think it is anymore. At the moment, there's a lot of interest in the right ventricle. There's new technologies, there's new studies. So there's a lot of work being done on the right ventricle currently. So I guess we've really caught up. And at the moment, I would say we're pretty much in par with the left ventricle, maybe even more so, because there's more and more data coming out now. What I just do want to mention is that echo is not the only modality that uses, that can assess the right ventricle function. I just have this noise here. Does anybody have his microphone on maybe? Yeah. Okay, thank you. What I just want to say is that the MR is still the gold standard, but be aware that it's not, it also has its limitations. So even though we call it the gold standard, there are limitations. So the important thing though, again, is just similar to the left ventricle. Why do we want to know what the right ventricle function is? The reason is quite clear. There's numerous of clinical situations where the right ventricle plays an important role. This is just, for example, the pulmonary embolism. If the patient has poor right ventricle function, we might need to go to thrombolysis. If patients have congenital defects, it might mean, should we operate on the patient already? Think of pulmonic regurgitation. If you have an assist device, the question will be, well, can we give the patient an LVAD, or does he need a total replacement of the right and left? Timing of surgery in tricuspid regurgitation, for example, how does a patient respond to treatment? So there's millions of these things. I don't want to go into details, but so right ventricle function is very important. And again, as with the left ventricle, we have so many different parameters that we can use. Visual assessment, we've got TAPSE, we've got the fractional area change, we've got the TDI velocity, 3D methods, and also strain. So there's a lot of things which can be done. And the problem often is that it's not so easy. This is such a classic example of a patient with poor image quality where we really do not know how good right ventricle function is. We do sense that the ventricle is enlarged, but we cannot really see the lateral wall. But in most situations, if you optimize the image, and I would really recommend that we kind of move the transducer a little bit more laterally to get an angle on the ventricle, which looks a little bit more like this here. Then we have a much better appreciation of the lateral wall, and that helps us tremendously. So I think this is one of the most important things to really get good image quality to allow us to assess right ventricle function. So this here now is the patient with a normal right ventricle function. You can clearly see that the contractility is okay. We see that the annulus is moving in I would say apical posterior motion. We have an inwards motion of the free lateral wall. This is an example of a patient with dilated cardiomyopathy where this is not the case. And this is clinically very, very important because this means that the patient has biventricular heart failure, which makes his prognosis worse. This is a patient who will then show symptoms of maybe ascites or pleural effusion. And here's another patient with pulmonary hypertension with very, very poor right ventricle function. Now, this might also be a very important factor. It might explain symptoms, but this is important also in the treatment decision. At the end, however, if you treat this patient, since it's usually an afterload problem, and if the afterload gets less, right ventricle function will usually improve. And this is a situation where we're probably confronted with most commonly. It's a patient who has severe tricuspid regurgitation and who has poor right ventricle function. And those are the patients where it's probably too late to operate on. This is why right ventricle function is so important to assess and why we should monitor these patients with tricuspid regurgitation so that we don't miss this critical window of when we can actually operate on them. Let me now turn to just, again, the visual aspect of it. And I think very similar to what we talked about with respect to the left ventricle is true here as well. Visual assessment can be done. It might be a little bit more difficult because the ventricle contracts a little bit different than the left. But I guess all of you will here agree that this is a very poor right ventricle function. This is almost a dead right ventricle. The same holds true for this patient here and also for this patient here. Patient with pacemaker. While this patient has normal right ventricle function. So what I'm trying to say here again is we can definitely determine which patients have a very poor right ventricle function and poor, and we can also determine the patients who have good right ventricle function. The difficulty will be in between, but maybe it's not so relevant to determine if it's mild to moderate or moderate to severe, as long as we find those patients who have some form of right ventricle dysfunction. That alone is of value here. So again, you see this patient here with a normal, patient with poor right ventricle function, and again, poor right ventricle function. I want to show you this extreme case because I think this also shows a little bit physiology. I was actually wondering why this patient was still alive, a patient who had a special form of autoimmune right ventricular myocarditis, where the right ventricle, as you can see, is really dead. He was even electrophysiologically dead. And if you look at what is happening here, is you see that the right ventricle is not contracting at all. The tricuspid valve is not closing. There's some degree of tricuspid regurgitation, but there's no pressure in the right ventricle to push the blood back into the right ventricle and right atrium. So the velocity is here very low, obviously, but the reason is that function is not present. And this is an interesting sign that you might see. First of all, you see that the mitral valve, the tricuspid valve is just flowing like a sail in the wind. It's just not closing, not opening decently. So this is just a very passive motion. It almost looks like a venous valve. And if you look at the velocity again, you see that there is no flow acceleration here because there is simply no contractility. And so these are findings that are just extreme parameters that show you that there's an extreme form of right ventricular dysfunction. Clearly, these patients have a very, very poor prognosis. The importance when I assess the right ventricle function is always to look at the outflow of blood from the right ventricle in the pulmonic artery, because that too gives me masses of information. First of all, under normal condition, we have a relatively rounded signal here. While in situations where you have pulmonary hypertension, you have a very short acceleration time, but we also see that the flow under the curve, the velocity time integral is very low. So this is the right ventricular stroke volume. And if you have poor right ventricle function, you have a very low velocity time integral. If it's combined with pulmonary hypertension, you would also see a short acceleration time. So alone, this signal here will already tell me very, very much about a function of the right ventricle. And here, coming back to this example I showed you previously of the dead right ventricle, this is the flow across the pulmonic artery, and you see that there is no systolic contractility or systolic flow anymore. It's just a continuous flow, which is probably more influenced by the respiration and by the negative and positive interthoracic pressure. So the right ventricle here is just functioning as a conduit where blood is just passing through or not passing through, maybe even retrogradely. So this is just an example. If you see such waves in the pulmonary artery, this also denotes very poor function. Very important when you look at the right ventricle, and if you assess it visually, is to use many views, because you have different components of right ventricle contraction. You've got the longitudinal contraction, you've got the radial contraction. And interestingly, in the right ventricle, more contractility happens because the ventricle is shortening versus the radial function. So to understand if function is deteriorating, you need to look at the longitudinal function, but also the radial function. Why? Because the magnitude with which the longitudinal versus the radial function contributes to ejection varies depending on the pathology. In this situation, for example, you might have a compensation of radial function because longitudinal function is poor, and vice versa. So you have to look at this inward motion. This is a short axis view. You see patient must have very high pulmonary pressures because we've got flattening of the interventricular septum. But what we also see is that this radial motion is definitely disturbed. And then here is the longitudinal motion. How do you assess longitudinal motion? Well, you look at how the lateral wall is moving in this direction. You can look at the annulus here and assess that, but be aware that longitudinal function is not longitudinal function. You have different function maybe in the apex versus the mid versus the basal parts. So this information is sometimes very, very difficult to interpret. So you have to look at all the different segments. The next very important message, therefore, is look at the regional function as well. This is an example where the patient has a reduction in the longitudinal function, especially here in the apex. While the basal segments seem to be a little bit better, the apex has a problem. Now let's come to the parameters. Now that we estimated the function visually, we'll take a look at the TAPSE first, because it's one of the most widely used parameters. And the reason is quite simple. It's a simple parameter and it's easy to perform, and therefore it's spreading like wildfire, which always shows that we need simple parameters to bring it into clinical practice. The abbreviation is tricuspid annular plane systolic excursion. I think you all know that. You know that we're using an M mode here, which goes right into the annulus of the tricuspid plane. And then we look at the excursion from diastole to systole, and we can measure that. And the cutoff value is 17 plus minus 24 plus minus 35 is what has been shown in the literature. So this is where you should be. From a methodological point of view, be aware though that if you have small ventricles, it's more difficult to obtain this value because you've got the lateral wall, which sometimes comes into this M mode and kind of makes the measurements more difficult. It's easier in larger ventricles, and you have to tilt the transducer a little bit so that you have a good angle to the annulus. The limitations, it's again only a regional parameter, only at the base of the right ventricle at the lateral wall. It ignores many portions of the right ventricle, such as the outlet portion of the right ventricle. It does not look at the septal contribution. I talked about the technical issues already, and that you've got this problem of the angle that plays a role as well. But do I do this parameter routinely? Yes, I do it. But it's only one of many parameters. So I do not base my decision on how good right ventricular function is solely on the TAPSE. I look at the other parameters as well. Let's come to the next parameter, which is the fractional area change. So this is kind of the parallel parameter to the Simpson method in a certain way, where we're looking at volume, or in this case, area changes. This is how you do it. You measure the area in diastole and then in systole, and then you perform a calculation where you look at n diastole minus n systole divided by n diastole times 100. So this is not truly right ventricular ejection fraction, because we're only looking at areas and not volumes. But it is a, I would say, approximation. The normal values here are 49 plus minus 7, and the threshold is less than 35, I would say. So if you have a fractional area change below 35, you would consider right ventricular function reduced. There are a number of problems, though. Again, as with TAPSE, it's very difficult at times to really delineate the right ventricle. And if you ever have the chance to go to dissection and see an open, true heart of the right ventricle, and you see how complex the structure is, you'll understand why it's so difficult to trace the endocardium. We've got many trabeculations there. It's very difficult to really trace the area of the right ventricle. You do not have the outlet portion in this calculations, and it's not the true volume. So these are some of the limitations. What do I do? Yes, I do it off and on if the parameters are completely, I would say, discrepant. I would also do the fractional area change, but personally, this would be one of the least parameters I would use, also for time reasons, because it takes more time. But what I do use in every patient for right ventricular functional assessment is I use the tissue Doppler velocity. Why do I use it? Because it's very, very simple. I guess you all know how to use post-wave Doppler, tissue Doppler. You select the region of interest. We use the basal parts of the free lateral wall of the right ventricle, and then just get a spectral tracing, which looks like this. Very easy to interpret. This is the QRS complex. This early peak is the isovolemic contraction. This is the systolic motion. This is the maximal systolic velocity, and then you have diastole early and late. We don't care about that, but we only care about this maximal velocity here. You see the reading here is 10, so we have 10 centimeters per second, and the normal values are somewhere in that range. 9, 10 would be a normal. The threshold, I would say, is somewhere in the range of 9.5. If it's below 10, you have to consider that the value is abnormal. And again, this is a parameter which is so easy and highly reproducible that I think it is a good parameter, but it too has its problems. It's not completely load independent, it's angle dependent. It again only shows you regional function. So in a way, it says pretty much the same thing as the TAPSE does. And they also fit together quite nicely. So if you see good longitudinal function with TAPSE, you also see it with TDI. Be aware, though, that here we're only looking at the longitudinal function. So we're looking at the motion of the myocardium along this line of interrogation, which goes obviously to the peak of the sector. So it's longitudinal function. This is another parameter which I just says the same thing again as I did before. It's this antegrade diastolic flow in the pulmonary artery. Artery, if you have that, then that would also mean that the patient has poor right ventricular function. This is just the second sign. Now, the last thing that I want to discuss is 3D. 3D is heavily being proposed now. Just as for left ventricle, there's now numerous analyzing packages where you record a 3D volume and do all these calculations. Yes, obviously, here you don't have the limitations that you don't have the inflow and the outflow. You have both in your region, but it does not tell you anything about the contractility, only it tells you something about the volumes that are shifted. It does not tell you anything about pre or after load because patients with TR might look better than they are. And from a methodological point of view, it's not so easy and it takes some time to really get these volumes good. It works in patients with good image quality, but it might be more difficult in those who do not have good quality. This is such a display. They look very interesting and of course fascinating, but in reality, they don't always give you all the information you need. Now, the very important part of assessment of right ventricle function, I think, is also the strain analysis. Maybe the strain of the right ventricle will be the modality of strain which will bring strain into the clinical practice in every lab, because I think that this is the best parameter, and there's more and more studies coming out that demonstrate that. Why is that the case? Well, first of all, we can not only look at a small region of function, for example, the base, but we look at the entire free wall. We get a number for the individual segments, and the studies have shown that we can use that very well. There's only one problem, that the reference values which are given in the guidelines, at least in my view, do not really fit. Normal values should be, I believe, much higher than has been proposed in the guidelines. So if you have a value of maybe around 25, I think that should be the lower threshold. This is minus 20. Usually you would have maybe in the range, in a healthy individual of 30 or so would be the normal value. So here would be an example of a patient with very poor function. You see that very low values are seen here. What about the septum? Well, the septum, there's been big discussions whether or not you should include the septum, because the septum is also here for the left ventricle. A certain part, certainly works also for the right ventricle, but I think that it's better to use only the information from the free lateral wall. So this, I think, is a very important part. In conclusion, I think right ventricle assessment is not as difficult as we think it is, especially if we train our eye to perform it in every patient. I think we need views that specifically image the right ventricle. So use slanted views, use views that demonstrate the lateral wall of the right ventricle, use maybe even a two-chamber view or an inflow-outflow view of the right ventricle. The second very important part is don't rely on one parameter, but again, the visual assessment should come first. If I would have to take one of these parameters to a lonely island with me, I would probably be strain. And then finally, if we look at right ventricle function, we have to understand the clinical impact of our finding. And if we do find that a patient has a poor right ventricle function, it also means that we need to answer that question within the same exam. And there are numerous causes which you see listed here, from pulmonary hypertension to tricuspid regurgitation, whatever. But be aware that if you write that the patient has poor right ventricle function, you need to also explain why function is poor. And the nice thing about echocardiography is we have the opportunity to diagnose all the things I'm demonstrating here, from cardiomyopathy to myocarditis to right ventricular infarct to pulmonary hypertension. So use this always in conjunction and put that into your report together with the assessment of right ventricle function. So I think it was a point landing. I think I made it exactly shortly before the webinar is over. I do hope that there are still some questions, and I'm very happy to answer them for you. Thank you very much.
Thank you, sir. It was a brilliant presentation. And more than 100 cardiologists are listening to you over the last 2 hours of time. If you have got any question, you can ask.
Firoze, can I ask a question?
Yes, Professor Abdullah.
Yes, sir. Thank you very much.
Before Professor Salam, we are very short of time because we have crossed our scheduled time. So make it
Yes.
Everyone is requested comments or questions.
Okay, sir. Thank you, sir. Actually, it was a brilliant, spectacular presentation. Very much logic and lucid and informative. I actually, as Professor Thomas told, the assessment of ventricular function, strain assessment is a game changer. So today, from his presentation, what I understood, Actually, he is a vision changer for the assessment of ventricular function in different cardiac conditions, starting from the physiology and mechanics of contractility, preload, afterload, and tamponade. He has nicely described. I really enjoyed. My question is for assessing a candidate for transplant in case of dilated cardiomyopathy, or in some cases of structural heart disease with valvular dysfunction. Do you use this strain as a final guideline for take the decision for cardiac transplant?
Well, thanks for your question.
Thank you very much.
Thank you very much also for your words of praise. I'm very, again, honored to be contributing here. I'll try to briefly answer this question. I use strain everywhere I can, and also use it for decision-making for valvular surgery, even though I do also respect the guidelines and respect that it's not in the guidelines. Example, patient has aortic stenosis, normal left ventricle function, ejection fraction, severe stenosis, no symptoms, but the patient already has a reduction in strain. This is a patient where I would monitor much closer. And if I do see that a strain starts to get worse and worse and the measurements are reliable, I would talk the patient into yes operation. Transplantation is a special topic because there I think you need to put many things into your conclusions. Definitely to diagnose a cardiomyopathy would be important, but I think it's also important if a patient starts to deteriorate rapidly from one to the other, I would also put him earlier to transplantation because it's not good to bring patients to transplantation when they're too bad. Patients who already have been transplanted, you can use it to look at rejection. We know now that change in strain from one exam to the other has a very good sensitivity and specificity to be an early marker of transplant rejection.
Thank you so much.
Thank you, sir. Dr. Nilufar, you want to make any comment or question?
Very brief. Make it very brief.
Yes, sir. Thank you, Dr. Thomas Binder. I am a big fan of yours. Sir, I use E9, GE E9, and we have only strain for software for LV, and I use deleting the septal segment. So, is there any? Do you think it's all right, or we need to do something more about it?
I think you can use the LV program also for the right ventricle. You have to play around with it, especially if you have a workstation echo pack. You can export the images and do it there. There's also a way, it's a little bit cumbersome, but you can do it on the E9 as well. So you can do the strain. I think it's reliable. I would still only use the free lateral wall. But yes, you can do it. I'm sure that the companies with the newest versions, they will also come out with the right ventricle strain package. So I would approach your representatives and just push them to give you the newest software so that you can do the right ventricle. And it's a pleasure to see you.
Professor Tuhin, are you with us? Professor Tuhin, do you make a brief comments? Professor Tuhin is the professor of Echocardiography, National Heart Foundation, Bangladesh.
Tuhin madam, please unmute. Unmute. Professor Tuhin madam, we can't hear you. Please unmute.
Now, can you hear me?
Yes.
Okay. So thank you, Firoze, and thank you, sir, for giving me the opportunity. I met Dr. Thomas in Jaipur and in Bangalore. So I took a picture with you, and I know your lecture, very brilliant and very practical lecture. You touched the practical points regarding LV and RV function. Especially, you pointed the importance of eyeballing of experienced echocardiologists. This is the most important one. The person, those we are doing everyday echocardiography, our eyeballing is the most important one. And you very nicely pointed out the importance of strain imaging, that it is additive to eyeballing, and it is additive ejection fraction. So it is not going to replace, but it will add additional value. So these are the learning points. And regarding RV function, you touch all the practical points. And I want to add that not only the parasternal, the apical view for RV evaluation, because RV is a complex structure. So we should go to the subcostal view also for evaluation of RV function. When we have the 3D, 3D is the most important one for evaluation of RV function. But with only 2D, we should go for all views, parasternal, apical, and subcostal view for total evaluation and RV function. And even in case of RV strain give additive information. And like as Nilüfer pointed out, with using VVD9 machine, we can calculate the RV free wall strain and RV global strain very nicely. So no limitation in calculation of our free wall strain by VVD9. Thank you, Thomas, for taking so much time and giving a brilliant lecture.
Well, thank you very much. First of all, pleasure to see you. Yes, I think just a little bit of a general statement that I think I'm trying to bring a message across, and that is we should not keep people away from ultrasound by making it more difficult than it should be. I think that those people that are out there in the practice and they're seeing millions of patients, they're doing hard work every day, they're gaining so much experience. And I think that what we should not do as an academic society is frustrate them by proposing certain technologies on them which are impractical and which actually keep them away from doing their job and helping patients. And I've learned so much from exactly people like you who've imaged so much and brought so much experience and their own theories that they've generated by seeing many patients. This is also one of the reasons I've really loved to go to the region of India, and maybe in the future also to Bangalore, because you see pathologies there, you see patients loads that are sometimes just so enormous and where we can learn so much. So this is just a very important part of, I think, what we need to bring across to our people. We need to expand the community. We need to give ourselves more value. I'm so thankful for getting all this feedback from you. With respect to your comment on the other views, I can only underline that 1,000,000%. I think 90% of the quality of the study comes not from generating new parameters, but it comes from good views, comes from free imaging using atypical views, which we've tried to standardize in ultrasonography and propose them also to the community, such as the inflow outflow view of the right ventricle, subcostal view, the parasternal right ventricle view. This is so important, and what we think is that the experience that you have out there needs to be shared as well. And I think it should be a balance between what your experience is to what the experience of the academic societies is, which is equally important. I'm not trying to reduce that, because and that comes together to form the knowledge we have to help our patients in the end.
Thank you so much.
Dr. Marshall, do you want to say something in brief?
Hello, dear sir. I am Dr. Roshan. Thank you to see you here. Long time I miss you. So do you use TomTech in RV assessment?
Yes, I've used the TomTech in the RV assessment. I think it's a very, very good program because, first of all, it's vendor independent. Even though Philips has bought the system, they still are independent, and you can use different companies. So they have a very smart approach to quantification, and I like their package. And I think it's many of the vendors have worked in the past with TomTech, and some of their software has actually been based on what TomTech has been doing. So they're definitely pioneered this area, and they're way up front there in the quality.
Thank you, sir.
Thank you, sir. I think we are running out of time. Thank you, Thomas Binder, again for your brilliant presentation, for taking so much time and sharing your experience with us. I am sure that our attendees will be very much benefited from your lecture. May I request Professor Abdullah, Shafi, Majumder to say a few concluding remarks.
Okay, thank you, Dr. Firoze and Dr. Monwarul for moderating these sessions, and thank you the faculty for participating in the discussions. My heartfelt thanks and gratitude to Professor Thomas Binder for elaborating the two topics in the single presentation And not only the theoretical presentation, it is also has got the important practical aspects. And the quotable quotes from you today is that don't make the fellows frustrated by making the things tougher, make the things palatable. This is also my vision, that keep the students, keep the fellows, keep the doctors attractive to this subject, not by making them frustrated, by making tough points to be raised. And that is the, I think that is the main learning for me from this session, that, and everyone should learn it, then make the things, always make the things simple, so that you can be successfully operate in the clinical practice. And I hope we can continue these sessions even hours together. I understand that so many questions are in the minds of our participants, but we have to close the sessions due to the time. And I hope Professor Binder will give us the more time in the future also. I will, if you permit, we can send the invitation to be connected with our webinar. And in the next year, if all the things go fine, we have got the open invitation for you to come to Dhaka whenever you get the time. And thank you very much again to get link, and thank you very much all the participants for making this session successful. Thank you very much. And also just one point, thanking the Beximco Pharmaceuticals who have co-sponsored this program on as the scientific partner, Beximco Pharma. Thank you.
Thank you.
Thank you, Professor Binder. Thank you. See you.
Thank you.
Thank you.